Should I begin? Yeah.
Yeah, I think so.
Okay, so thank you everyone for coming to and logging into the latest edition of What's New in Addiction Medicine, presented by Addiction Medicine and other addiction fellows regularly. So my name is Ram Herring. I'm the Victoria Site Director for the Addiction Medicine Fellowship, and I'm very excited to present Megan Woolner today, who is one of our Victoria-based Addiction Medicine Fellows, as she presents her What's New in Addiction Medicine presentation. So just a little bit about Megan. She obtained her undergraduate degree in anatomy and cell biology from McGill University of Montreal in 2014 and graduated from the University of Toronto Medical School in 2018, where she won numerous awards for exceptionally high academic achievement. She completed the UBC Family Medicine Residency Program at the Victoria site in June of 2020, after which she started her Addiction Medicine Fellowship here in July of 2020. In addition to addiction medicine, Megan has a strong interest in obstetrics and perinatal addiction, an area which she's currently doing research, quality improvement, and advocacy work. Has been a huge addition to our Victoria perinatal addiction community. Megan has a very strong sense of social justice, a deep understanding of how the social determinants of health profoundly impact patients struggling with substance use disorders in a myriad of ways. And for her What's New in Addiction Medicine, she will be presenting today on the very topical and rapidly evolving area of decriminalization and legal regulation, which undoubtedly will be a very important part of how we address the opioid crisis going forwards. And she'll be joined by Caitlin Shane, a lawyer with Pivot, who Megan will introduce. So thank you all for coming.
Thanks for the introduction, Ram. I appreciate those modifications to the bio. So I just wanted to introduce Caitlin, who is going to be my counterpart during this lecture today and has been kind enough to join me. Caitlin's a staff lawyer at Pivot Legal Society, a human rights legal organization based in the downtown east side of Vancouver. As Pivot's drug policy lawyer, Caitlin takes direction from drug user-led movements and advocates for the decriminalization of drug possession and the legal regulation of all drugs. Caitlin first began working in the downtown east side in 2010 as an outreach worker, providing frontline services in SROs, supervised consumption sites, emergency shelters, and tent cities in Vancouver and Victoria. And we're really lucky to have her today to bring her expertise to this discussion. So once again, thanks for joining. And we're going to be talking today about drug decriminalization and legal regulation. I want to start off our talk by acknowledging the lands that we're lucky enough to live and work on. I am joining from Victoria on the lands of the Lekwungen peoples, the Songhees and Esquimalt, and the Osanek peoples of the Coast Salish Nation. And Caitlin is joining us from Vancouver on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. To begin our talk, I don't have any conflicts of interest to declare. I do think it's important early on that I acknowledge that this is a controversial topic and many people have complicated feelings, especially about safe supply and legal regulation. I've attempted to review the available literature, but in general, this is not necessarily a topic with clear answers and often one which evokes strong feelings for people. I do think it's important for us to have a safe space to objectively discuss these topics, and I welcome all opinions during our discussion, and I hope to leave ample time at the end of the lecture to have a fruitful discussion. I also want to acknowledge that despite the series title, neither of these concepts are particularly new, and in fact, people who use drugs and advocates have been calling for decriminalization and a regulated drug supply for many years. Overall, I certainly don't have all the answers, but I'm hoping to open a discussion on these pivotal topics in addiction medicine and expand the conversation around alternatives to our current drug policies. This is a quick overview. We're going to talk about decriminalization and some of the models for decriminalization. And then we're going to particularly talk about a model for Canada with specific focus on the proposed model for Vancouver. We're going to talk about the concept of legal regulation and then review possible models for legal regulation and then leave time for discussion. So hoping to speak for about 40 minutes and then leave the remainder for discussion. The objectives are for individuals to gain an understanding of the approach to decriminalization and what could work, especially in the Vancouver context, to review the concept of legal regulation and a few possible models that could be utilized, and then open discussion. I am going to attempt to use Poll Everywhere during this discussion, but this is the first time I'm doing this, so it may or may not work. But you can always just pull up this link. So it's pollev.com/MeganWoolner917. And it won't show anything right now, but when I go to those slides, it will activate. And it will come up when the questions are present. I think probably a lot of us have a sense of the relevance for this talk. In BC and Canada in general, we're struggling with an overdose crisis that has only worsened during the pandemic with an increasingly toxic drug supply. In our current society in general, the focus has been shifted onto systematically addressing racism and police brutality. I think it's important to comment the establishment of criminalization in general is steeped in racist ideologies. Additionally, we've seen an expansion of safer supply initiatives in the context of COVID and the risk mitigation guidelines from the BCCSU, which have fueled discussion around safer alternatives to the current drug supply. Most notably, this is a topical discussion as the City of Vancouver is working on a model of decriminalization, of which a preliminary draft has been submitted to Health Canada in March and updated in April of this year. I wanted to just start off our discussion reviewing this relatively infamous diagram on various approaches to drug policy. So I think it's important to point out that we see that the health and social harms are highest at both ends of the spectrum. And it's been definitively shown through the literature that the current prohibitionist approach to drug policy has failed to achieve its stated ends. That is to prevent the growth of a legal drug market, to curtail use of illegal substances, and to prevent harms associated with the use of these substances. Unfortunately, this approach, which we can see here on the prohibition end of the spectrum, has magnified harm through the creation of a highly toxic illegal drug supply and the criminalization, stigmatization, and marginalization of individuals who use substances. It's time for us to acknowledge that the ineffectiveness of these policies is clear and shift toward more public health policy approaches to reduce health and social harms of drug use in our current society. And so the public health approaches come in this middle area here, where health and social harms are minimized. So our first topic today is decriminalization. I just wanted to start off by bringing up a segment from a document that was released in 2015 by the International Network of People Who Use Drugs. It's called The Rights of and Demands from People Who Use Drugs. And the very first demand is very applicable today, which states people who use drugs and drug use must be decriminalized. And this is an important sentiment that's gaining traction in Canada, but certainly in Vancouver especially. We're going to do just a brief review of the current legislation. So the Controlled Drug and Substances Act, or the CDSA, was enacted in 1996 and is the legal framework that remains in place to this day for management of illegal substance use. This federal legislation monitors or encompasses concepts of possession, trafficking, importing, exporting, production, etc., all of which are criminalized under this legislation. In Canada, there's two contexts in which possession of a controlled substance is legal, and that is by prescription by, for example, a physician or a nurse practitioner, or via federal exemption, which is the Section 56 exemption, which is how supervised consumption sites work. And we've talked about it briefly, but I think it's just important to reiterate that a lot of the establishment of criminalization in general has been steeped in racism, and the division between legal and illegal substances is relatively artificial and doesn't really hold up to logic in terms of potential harms, but is rather an artifact of our social and political history. For example, we often separate alcohol and tobacco from other drugs, but alcohol, at the very least, is a psychoactive substance that has potentially highly toxic, addictive, and associated effects and associated with high mortality rates, despite by being by definition legal. We're going to briefly touch on the benefits of decriminalization, but I'm not going to focus on this too much, as I think it has been made quite clear. As we talked about, the war on drugs has failed from the perspective of decreasing drug use or decreasing the illegal market, and has resulted in criminalization and stigmatization of people who use drugs. It has increased the inequities for ethnic minorities and those of lower socioeconomic status, as disproportionate arrests for are common for Black and Indigenous Canadians, despite similarities in illegal substance use across racial groups. It's costing the country a lot of money in terms of police funding, and the majority of apprehensions are for simple possession in low-level offenders. It is, in many cases, been shown to be deterring people from harm reduction practices, which we know save lives, including various ethnographic research studies in the downtown east side showing that increased police presence compromises safer injection practices and deters the use of overdose prevention sites. As we've mentioned above, it drives stigma against people who use drugs, and additionally has created and fueled a robust illicit drug market of increasingly variable toxicity. I thought this was a nice diagram from the HIV Legal Network report on the need for decriminalization, which just outlines the abundance of resources that are spent each year in the enforcement of simple possession in Canada. For example, between 2008 and 2017, there were just under 250,000 offenses under the Controlled Drugs and Substances Act in BC. And as is the case in other jurisdictions across the world, the majority, which is 81%, were for non-violent offenses for simple possession. And as we talked about, the majority of individuals apprehended for simple possession of drugs are low-level offenders. We know these arrests disproportionately impact those of low socioeconomic status and individuals who are Black and Indigenous. We also know that exposure to the criminal justice system comes with a variety of harms, including trauma, increased risk of infectious disease like Hep C and HIV, higher risk of overdose at discharge, stigma, and difficulty reintegrating into society following discharge, to name a few. And yet, despite the fact that we know that prohibition and criminalizing people who use drugs has not decreased drug use and has led to significant harm, the Vancouver Police Department, for example, continues to have an expanding budget. And in fact, $340 million is the projected budget for the Vancouver Police Department in 2021, which is approximately a fifth of the city's operating budget. This funding urgently needs to be redeployed from enforcement to health and social services. And Caitlin is just going to speak to the different ways of approaching decriminalization.
Thanks, Megan. Yeah, so I think, there's a lot of discussion right now about decriminalization, and more specifically, there's a lot of finger pointing happening at various levels of government in terms of whose responsibility is it to deal with this issue. As Megan mentioned, the Controlled Drugs and Substances Act is the overarching piece of legislation governing drug-related activities in Canada, and that's a federal piece of legislation. So technically, when we're calling for decriminalization, the most straightforward means to get there would be to have the federal government amend or repeal parts of that federal legislation. And that is a very specific type of decriminalization that is called de jure decriminalization, which means basically you are actively, formally changing policy and law such that the law would no longer make it a criminal offense to possess drugs for personal use. But I also think it's important to draw attention to other ways of decriminalizing, or at least having the same effect or a similar effect as decriminalization, that don't necessarily require those formal channels to be moved through. So de facto decriminalization is a term that we use to describe non-legislative or informal means to achieve the same goals of decriminalization. And part of why de facto decriminalization is appealing is because it's an option that's available to municipal governments, provincial governments, also the federal government. It can oftentimes happen more quickly than de jure decriminalization, because de jure requires, the formal legislative process. And what it can look like is relatively flexible and can be different depending on the needs or desires of a given jurisdiction. So you could have, for instance, a local police department adopting a policy of non-enforcement when it comes to a particular offense. So the offense itself is still criminal on the books. The criminal code hasn't been amended or repealed or whatever, but the practical enforcement of that law has changed in a given jurisdiction. Many of you might be familiar with when Dr. Bonnie Henry recommended a couple years ago that the province of BC amends its policing legislation so that police are no longer able to expend resources, including police officer time, on the enforcement of simple possession. That would also be an example of the province taking a de facto approach, albeit adjusting its provincial legislation. It still leaves the criminal offense on the books. So we advocate both for the gold star standard of de jure decriminalization, but in the interim, if we can do it, let's get as many jurisdictions as possible going for de facto decrim en route to this kind of longer standing, more formal change.
Perfect, thanks for that. And so with that, we're going to just spend a very brief period of time talking about the Portugal model of decriminalization, as it's something that often comes up in the conversation when this topic is brought up. So since the adoption of partial decriminalization in 2001, Portugal is frequently cited as the most important example of successful decriminalization of drug use and of people who use drugs. It is, however, important to point out that this is not full decriminalization. So drug possession in Portugal is still illegal, but possession for personal use is not subject to criminal sanctions, and an individual apprehended under this law receives a citation that requires an appearance before one of the regional bodies that are called the Commission for the Dissuasion of Drug Addiction. And responses from this committee include dismissal with a warning, referral to health and or social services, referral to treatment services, fines, restrictions, or community service. As you can see on the slide, there's a variety of benefits to partial decriminalization in Portugal, which include decreased incidence in HIV in people who use drugs, decrease in the number of overdose deaths, decreased proportion of prisoners incarcerated for drug-related offenses, which dropped by about half following this decriminalization, decreased stigma and using alone, which is a very relevant point to bring up, especially in the BC context, with the BC coroner's data showing that the majority of overdose deaths happened for individuals using alone and indoors. And then importantly, something that's often brought up is concerns of increased substance use with decriminalization, and that was not borne out in the data following decriminalization. I think it's important to also review some of the downfalls of the decriminalization model. As I said, it's not full decriminalization, so it continues to focus on decreasing drug use and dissuasion. Certainly, this is something that some people may think is optimal. Unfortunately, in how it's conducted, it continues to further stigmatize and undermine the agency and self-determination of people who use drugs. It's generally argued that larger possession must not be decriminalized for fear that then we would not be dissuading dealing, trafficking, and selling. However, reports from Portugal suggest that it means that people with more significant substance use, and often individuals with substance use disorders, tend to have more than the legal amount, which is approximately 1 gram of heroin. This means that they still receive criminal sanctions. And unfortunately, these tend to be the most marginalized group of people who use drugs. We'll come back to this later, but this is what makes discussing and choosing a threshold such an important topic when we're creating a decriminalization policy, as there can be unintended harm with conservative thresholds, and that's been seen in across the globe when people have implemented different models. In Portugal, for example, police will still stop and search individuals, which disproportionately happens to poor and racialized people who use drugs, and drugs are still confiscated if found by the police. Lastly, in terms of things to consider for improving this model, although the Dissuasion Committee is a step in the right direction with more of a focus on health than criminalization, It enforces administrative penalties and offers what is titled as voluntary treatment, but undoubtedly there's a question as to whether or how voluntary this treatment is, as the alternative is a sanction, and often people feel compelled to choose treatment than, for example, having to pay a fine which they may not be able to afford, especially when the penalties are very costly. And I just wanted to pull this up briefly. This is the concluding shot in the community-driven evaluation of the outcomes of Portugal's decriminalization of people who use drugs. So although Portugal is often brought up as the most progressive country and an excellent example of decriminalization, we need to make sure that we in our local context. So from there, what should we consider in our model here? So it's important that we learn from the policies in place in some capacity from 30 other countries around the world. In Canada, we need to consider full decriminalization rather than partial decriminalization. Yes, this is a health issue rather than a criminal justice issue, but it's also an issue of policies that have been racialized and perpetuating structural inequities for decades. Without full decriminalization, people who use drugs will continue to be stopped and searched. The most marginalized drug users will continue to be disproportionately impacted by sanctions. And we must be extremely cautious in defining thresholds that reflect real patterns of drug use, of drug possession for people in a local context, with the help of people who use drugs to avoid the unintended harms of conservative threshold estimates. All of this is important while shifting funding towards health and social services to ensure people are able to meet their needs, whether it be for housing, addiction resources, or publicly funded treatment options. But this should be up to individuals. We're going to just briefly review what's happening in BC. And as Caitlin brought up, in April 2019, our lovely, very infamous public health officer recommended that drug use for personal use be decriminalized and released a report called Stopping the Harm, which outlined how this could be done at the provincial level. Unfortunately, drug law reform at the federal level has not showed much progress, and therefore municipal and provincial governments have taken steps to decriminalize locally. In December of last year, our mayor, well, not our mayor, Vancouver's mayor submitted a letter to the federal Minister of Health requesting exemption for the city of Vancouver under the CDSA. In February 2021, the BC Minister of Health and Addictions similarly put in a request for provincial exemption. In March of 2021, Vancouver submitted a preliminary proposal to Health Canada. And then actually on April 8th, they updated the submission with a 3-day threshold outlined. And so we're just going to briefly go over what the Vancouver preliminary exemption model entails. And there, it's like a 16-page document. It's not too long. It's available on the city's website. And there's one for the preliminary exemption model that was originally submitted, and then there's a follow-up one for the threshold determination. So the preliminary model defines 3 main components: a personal use threshold, voluntary referral to services, and incorporation of the overdose outreach team and expansion of those services. And then lastly, decision making, which essentially means that discretion would be placed in the hands of Vancouver police officers in terms of charges if somebody was found with possession over the so-called threshold limit. Currently, it does not advise administrative penalties or sanctions to replace criminal charges for those found with possession below the threshold, which is very important. We're going to take a minute to speak to the outlined thresholds. So there was a document submitted, as I said, on April 8th, 2021, which outlined the proposed threshold amounts. Generally speaking, as we've mentioned before, determining thresholds for personal use can be really challenging and difficult to decide upon. There's no ideal threshold for personal use, and setting the amount too low will undermine the goal of decriminalization and potentially lead to increased charges for people who use drugs. Additionally, there's a lack of evidence that a higher threshold would enable drug trafficking, which is often the concern that's brought forward. So these thresholds, which are outlined here, I don't know if you can see my actual clicker, but this is the ones that are defined for Vancouver, or proposed for Vancouver. And these were based on using data from these studies, all of which were conducted in 2019 or earlier. So the threshold is actually based on the top quartile, which essentially was the average amounts in the upper quartile of the range of amounts reported. In their proposal, they actually go through like exactly how they figured it out. And there was various different steps of figuring out the amount of money spent on substances and then changing that into the actual amount of substance. And these thresholds are for a 3-day supply. And they did entertain the idea of a 3-day supply, 5-day supply, and 10-day supply. The report itself does acknowledge that there's issues with the data, but I think it's really interesting to look at like the top quartile versus, for example, an average of the maximum amounts. And I just go to the next slide, which is actually from the report, and it shows the variation. So here we can see the 3-day supply, which is what they've decided to propose. And the upper quartile range is 1.95, so they've used 2 grams for opioids, but yet the average of the maximum amount of substance use was 13 grams, which is a significant discrepancy.
And I would just add to that, so there's been, I mean, obviously it's tremendous progress that the city is considering decriminalizing, but if I can provide some input or feedback from directly impacted communities, that feedback is, you know, very legitimately concerned about the thresholds potentially being too low. There was concern that groups like the Vancouver Area Network of Drug Users were not consulted adequately in the process of coming up with these thresholds. Pivot and Bandu issued a joint statement warning against thresholds that were too low, because as Megan said, if the threshold is too low, we actually risk doing more harm than good, because currently the case law and the law itself remains relatively silent on the threshold amount distinguishing between possession and possession for the purposes of trafficking. And if we impose threshold amounts that are actually lower than what's currently contemplated by the case law, we end up making a more restrictive regime in many ways than we already have. And I think our primary point was that you have to have threshold amounts that reflect real world drug use, and not just drug use, but drug purchasing. So obviously since 2017, when much of this data was collected, there's been an opioid crisis ongoing, a toxic supply, and there's also been COVID. And those things have very deeply impacted patterns of purchasing. So I've talked routinely with people at Bandu who say, since COVID, with stay-at-home orders, their patterns of purchase have changed significantly. You know, they're leaving the house less often, so they're buying in bulk. The supply is less predictable, so they're buying larger quantities in the event that what they get is not what they expected it to be. Folks with mobility issues who can't leave the house every day to go purchase. Folks who live in rural and remote areas who don't have access to their dealer every day. The fact that drug purchasing is criminalized by definition means that people are going to make fewer purchases to avoid the threat of criminalization that attaches every time they make a purchase. So there's concern that these threshold amounts do not reflect 3 days worth of purchased amounts. You know, at the Bandu board meeting I attended last week, they were saying, you know, that could be what I have in a morning. And yeah, that's a lot, but that's the reality. And also the purpose of decriminalization is precisely to protect folks who are disproportionately criminalized. And that is exactly that demographic of people who now will not be protected by the proposed thresholds. So there's a lot of concern around that. There's also concern in terms of residual police discretion, not only in the development of this plan or model that actively left out people who use drugs, but also in terms of even police having discretion to interact with people and provide referrals. It's hard to say that that is voluntary when we know, you know, that any interaction with police is not always experienced as voluntary if you are a poor racialized person. So there's a lot of concerns that are ongoing, and I think our advocacy needs to continue.
Yeah, I think those are really fantastic points. And I think that in the document, they did outline that they were seeking consultation. And so I think it's important for us just to all be aware. I was going to pull up my first potential poll, so I'll do that as I talk. But hopefully this will work if people text in. Although it says start the presentation, so I'm not sure if it's going to work. But yeah, I think it's important to make sure that we're all kind of involved in the evolving discussions, as this is really just like a preliminary proposal based on really what is outdated data. And also one of the studies that was used to create the threshold was a study following youth or at-risk youth. And additionally, the exemption is not at the moment going to include youth. It's specifically for adults. I think this is maybe not working, so I'm going to skip it. So decriminalization, as we talked about, is certainly an important step and something I think it's great that this is ongoing discussion in Vancouver and a first step in shifting our drug policy. But even if simple possession is decriminalized, if nothing else changes, it means ongoing toxic drugs, drug confiscation, and forcing people who use substances to have continued exposure to dangerous and potentially violent environments to obtain unregulated drugs, which is something that Caitlin had brought up. And that brings us to our second topic, which is the topic of legal regulation. I'm just bringing us back to this document from the International Network of People Who Use Drugs. And their 13th demand was that barriers to health must be undermined and dismantled. Not only must people who use drugs be decriminalized, but drug use or drugs must be produced in a legal and regulated context. So I'm going to be very, very brief. This is not legal regulation, first to distinguish it. But I just thought I would be remiss to not briefly take a moment to talk about risk mitigation and recent implementation, mostly as a jumping off point of things that we can learn from kind of what is the current safer supply model and some of the downfalls of it. So as we know, most of us probably know, the BCCSU did release the risk mitigation guidelines in March in the context of the COVID-19 pandemic, which are generally kind of used now to facilitate broader safer supply prescribing and initiatives. There's been a lot of uptake in certain hubs, so Vancouver, Victoria, and other cities, but there's difficulties in terms of geographic reach. Additionally, this is a clinical guidance document that is not evidence-based, but was released expediently in the context of the unknowns of the COVID-19 pandemic. Unfortunately, at this time, we have limited data on the initiative available thus far, though I do know that it's being monitored. I just wanted to briefly review some of the shortcomings of the current safer supply model as a jumping off point for our discussion around legal regulation. So I did include briefly in the subpoint some information from a chart review, which was done by the Kool-Aid Community Health Center in Victoria, which is a health clinic which services most of the inner city population here. And they did a chart review on risk mitigation prescribing, particularly looking at clients who received prescription opioid stimulants between March and August of 2020. In terms of some of the shortfalls with this current safer supply model, prescriber-driven regimens are problematic for a variety of reasons, including limited person power, difficulty analyzing benefit, limitations and options available, and moral distress around lack of evidence and like policing around diversion in quotation. There's limitations in the medications available through this guidance document, which make it challenging. So for example, hydromorphone 8 milligrams up to 14 tablets a day is outlined in the document. And in the Kool-Aid review, there was a correlation with higher hydromorphone doses leading to higher continuation of risk mitigation prescribing. And the most common issues that were charts in the Kool-Aid review was that the risk mitigation doesn't have legs, i.e. doesn't last in the same way that their other substances might, was not helping greatly, or that they could barely feel it with little or no effect when using the entire dose at once. Additionally, the current model does not lend itself well to different modes of consumption, as there are inherent harms, for example, in injecting dilaudid tablets. Therefore, there's a need to provide a broader availability of substances that would facilitate different means of consumption. In terms of final kind of comments on this, this is inherently a medicalized model, which may not ultimately be the most beneficial one for providers and patients. So now we're actually going to talk about legal regulation, but I thought that was a good jumping off point, and Caitlin's just going to describe what that actually means.
Yeah, thanks, Megan. So legal regulation is obviously something that people have been calling for a long time, partly because of the fact that decriminalization doesn't address a toxic drug supply, and that is overwhelmingly, at play in the context of overdose fatalities. So legal regulation basically refers to the process of making something legal and then tempering or constraining its access through the use of regulations. And we legally regulate all sorts of things, whether it's tobacco or alcohol or driving a car, toothpaste, like everything is regulated. So it's actually a concept that people attach a lot of fear and concern to it in the context of drugs, but it's something that we already do all the time in relation to drugs and other substances and actions. And the idea behind legal regulation is really to add a level of control and accountability in terms of the process itself, so ensuring that we know the substance has met a particular standard. We know what's in it when the purchaser purchases it. They know what they're getting. And also to control access to it. Who can access it, how they can access it, where they can access it, what other conditions need to be present in accessing it. And I think, without getting into all of the nitty-gritty details of legal regulation, the best thing to keep in mind is that legal regulation is incredibly flexible, and the benefit of it is that it can really be tailored individually to different substances and people. It doesn't have to be a blanket policy in the way that prohibition does and is in Canada. It allows us to take an appropriately contextual and nuanced and informed approach to drugs in Canada. And I think it also does something that prohibition doesn't, which is address the demand side of things in the equation. Prohibition deals only with supply. It aims to blot out supply, forgetting the fact that people have and always will need to use drugs for various reasons. And so long as there is a demand, a supply will crop up, regardless of whether you criminalize it. The only outcome of criminalizing it is that there's going to be an illicit underground supply, which thrives under prohibition and which would be chipped away at under legal regulation. The idea being, if you provide people with a legal avenue to access the substances that they need, and of course that access will be tapered, but if you provide people with an access point that is legal, there's less need to rely on an illicit, toxic drug supply. So legal regulation is very much the middle ground between a free market and prohibition. And ironically, prohibition is more or less a free market in the sense that it's profit driven, and that access is entirely unregulated and uncontrolled. Any one of us can go purchase drugs on the street right now. That's more or less a free market that we have under so-called prohibition. So I think that's it for the legal overview.
Yeah, I think that was really well put. And we're going to just talk, I'm going to kind of skip this slide, I think, just for timing purpose, because I want to maintain time for discussion. But this is just the Global Commission on Drug Policy report from 2018, which clearly outlined that prohibited drugs should be regulated. It's a really interesting read if you have time. In terms of benefits, there's an abundance of potential benefits to bringing drug markets under governmental control. So the concept of considering legal regulation acknowledges that drugs are dangerous and that drug use can be risky and therefore needs to be regulated. Prohibition, as Caitlin described, has driven in a legal market that has no government regulation. And ultimately, drug policy should aim to reduce drug-related harms, so real control means taking that market back from criminal networks and bringing them within the government sphere, where drug production, supply, and use can be regulated as strictly as deemed appropriate for any given substance. Additionally, legal regulation would provide access to prescription-grade drugs, work to disempower organized crime, and decrease fear and stigma around substance use, which may decrease the threshold for people to seek different supports and addiction services if they wish. And then additionally, there would be the potential of more equitable access if it's not necessarily prescriber driven. I've just quit on the poll everywhere thing, so we're going to skip that. We're going to briefly talk about options for legal regulation. And I would just comment there's a variety of different options and models that could be used, and they're all generally based on existing models. And so there's a lot to be learned from cannabis regulation as well. And there's benefits and downsides to each model. So towards the left of the screen, we see kind of more restrictive models. And then as we move over to the right side, we're seeing less restrictive models. And like Caitlin said, that legal regulation is flexible. And so we might even have different frameworks for different substances. And additionally, like it could be a graded approach where, you know, certain substances initially are available and then we move to others and learn and evaluate as we go along. As we talked about, prescriber-based models do have downsides, which we have seen with the risk mitigation guidelines in terms of limited people power, but also limited access based on geography. However, they may be a good option for the most risky substances. And this is something that we're seeing in some pharmaceutical alternative programs already in certain capacities. A less medicalized model is that of the Heroin Compassion Club or cooperative approach, which was outlined in a BCCSU paper from 2019, which is quite an interesting read. But essentially, heroin or other substances could be restricted to members and legally obtained from a pharmaceutical manufacturer and securely stored much in the same way as it already is for heroin prescription programs. When we continue along, we're looking toward more or less stringent models. So the option of licensed retailers, which is what we see with cannabis regulation, could be considered for certain substances. And then lastly, for some substances, a model such as a licensed premise, which the examples of that are kind of the Dutch coffee shops for cannabis or opium lounges could be reviewed. As we talked about, implementation could be phased and likely certain drugs will be legalized and regulated first, as in our case has already happened with cannabis. And generally the default position would be to err on potentially the side of stricter regulation, and then it could be relaxed when we're looking at the evidence of safety. And I think it's important to not, like we said, it's not a free market. And so certain activities would remain prohibited, and this can be determined with policies. But for example, underage sales, which we see with alcohol, consumption in certain public spaces, unlicensed sales, advertising would be a big one, and other considerations. I wanted to just bring us back to this curve that we started with that looked at drug policies. And like we talked about, prohibition essentially makes a free market in terms of the illegal market. And then on the other end, we're seeing completely unregulated legal markets. And we want to minimize the harms and keep legal regulation kind of squarely in this section through different policies. And of course, there will be different commercial and free market forces that push things further towards the right. But it's critical that government and public health regulation contain these commercial forces. And so that brings us to some concerns with legal regulation. A large part of the framework of legal regulation would be focusing on carefully monitoring its implications and effectiveness as we would with any policy intervention. Concerns have been raised around the significant harms of alcohol and tobacco in our current society, which are legal, but these are actively commercialized substances, and legal regulation models could be much more stringent regarding access and distribution of other substances as mentioned. And as we talked about, it would be very important for government and public health to regulate kind of the commercial interests that would be at play. Lastly, concerns are brought up about the difficulty of striking a balance between adequate control over supply and ensuring the ability to compete with the illicit market, which can be challenging. So, higher prices might discourage use or entry kind of into substance use potentially for certain is argued at times. But at the same time, if prices are prohibitive, then we're not actually competing with the illicit market, which makes it essentially futile. We're going to skip that. So that brings us kind of to next steps. So I put a few things on here which I thought were very topical. So I received an email in March when I was preparing this presentation from Doctors of BC asking for my opinion on decriminalization and safe supply. And so I think it's just important that all of us, regardless of kind of our opinions, that we do make ourselves part of the conversation. And then this is a timeline for the Vancouver decrim policies. And so as they say in April and May of 2021, so right now they're looking for public engagement to discuss the risks and strategies for this. And lastly, I actually just got an email yesterday about these sessions with the government around pharmaceutical alternatives. So if you're interested, certainly I can provide the information around that. I did want to just very, very briefly just bring up some of the current initiatives. A lot of them in terms of pharmaceutical alternatives right now are medicalized models, and they're prescriber driven, and most of them focus on opioids, but just important to be aware of. In terms of further information, if people are interested in reading, Caitlin actually authored this wonderful report at Pivot around the decriminalizing drugs in Vancouver. It's an incredible read. This is a report on the different models of decriminalization across the globe, which is also a fascinating way of learning kind of what works and what might not work in policies. And then over here we have Transform, which is has reports on blueprints for regulation and talks a lot about different models of legal regulation. And then Crackdown is a great resource, and this is the Heroin Compassion Club paper I was speaking about. These are from the initiatives in Vancouver. Unfortunately, we did not have a safer Victoria, so I had to take one from Vancouver. And I just wanted to acknowledge all the people who have helped me to prepare this presentation, providing mentorship, guidance, and suggestions. So thank you so much. And thank you, Caitlin, for being here today. These are the references. And then I think we have saved about 12 minutes, hopefully, for some group discussion. Happy to answer any questions or take comments from the audience.
Thanks very much for that great review, Megan. There's lots of areas we could go with for discussion. I'm just waiting to see if there's going to be some questions that are coming in from the group. I think it looks like there was about 55 people. Raman, any questions coming in? I don't see if there's any. Not sure if there's no questions or they just haven't gotten to me. I don't see any, or anyone can feel free to put any questions into the chat, any things you'd like to further discuss. So I've lots of questions, lots of things that I could ask. I'll ask one topic for one area that has been, I think, difficult for a lot of people to try and figure out a way to approach, is related to prevention and youth. And obviously, all of us want to do whatever we can to reduce stigma and to lower barriers and to ensure that people who are using or who are negatively affected by stigma as a result of their use. How do we balance that with still trying to have some efforts at prevention with youth, where we are trying to discourage youth from using drugs, at least while they're young. I'm just wondering any thoughts, Megan, if you have on that. I know that's not a softball, I don't think.
Yeah, I mean, I'm happy to comment, and then I'll let Caitlin fill in the gaps that I have. But yeah, it's actually a really prevalent question that's addressed in the literature kind of around certainly decriminalization models across the globe. And in general, like what the data has shown from decrim, which is not necessarily legal regulation, but even legal regulation of cannabis, is that there's not been significant increases in youth. And in particular, there's been an interest always in youth using substances more with these models. And then I think the other piece is that we should really be shifting, like we're currently using a discouragement of substance use through criminalization, which is really, I don't think the best model. And rather, it's not that we want to encourage use and youth, we want to discourage it, but we could use a public health approach to this, which is what we use, for example, with nicotine or tobacco. And then I think lastly, yeah, and then I think, like we talked about, that we can still prohibit certain activities under a legal regulation framework, including kind of sales to youth. But I don't know, Caitlin, do you have other thoughts around that?
I would just say that, I mean, in Portugal, decriminalization was found to reduce quote unquote problematic substance use, which included youth substance use. So far from actually deterring drug use, criminalization, decriminalization has had the intended effect of limiting youth drug use. And then the other point is just that I think always keeping in mind the social determinants of health, things like employment opportunities, education, housing, appropriate income assistance rates, all of these things that lead to certain types of drug use can, you know, if we address those things, we have a better chance of addressing the reasons why people use drugs in the first place.
Okay, so it looks like there's a few questions coming in here. What would be examples of countries having a fairly high degree of decriminalization? Is there good data available from these countries? Yeah, any comments on that?
Yeah, I mean, Portugal is obviously one of them. It's not really a high, their threshold is not high in Portugal. I'm trying to think of the other locations, because certain places is more certain substances like cannabis. Do you have any off the top of your head, Caitlin, that you?
There's very few other jurisdictions that have fully decriminalized, like even in Portugal, it's just partial decriminalization with criminal or administrative regimes still being used. Uruguay has made some progress in terms of not having administrative sanctions, and the data there indicates much the same as Portugal. But yeah, we don't really have anywhere to look to in terms of like threshold amounts that reflect actual patterns of drug use. We just have negative feedback from places like Portugal where thresholds are too low and people continue to be harassed and have their drugs confiscated by police.
Great, thanks. So another question, comment, awesome talk, thanks. I know much of the focus is on opioids. Wondering about evidence or concerns around stimulant legal regulation given context of psychosis, if it were to be outside of prescriber regulated supply.
Yeah, I think it's a great question. And I think like there is not, unfortunately, that much information about legal regulation of different substances. Like the most accessible thing is the cannabis regulation. And as far as I know, Caitlin, definitely correct me if I'm wrong, there is not somewhere that's currently legally regulating stimulants. And I think it's an important question to bring up, like if it's not under prescriber driven. But I think the other concept is around like people will choose to take risks, and they do that in all forms in life. For example, like driving a motorcycle, which is something that under law is totally reasonable. And so, you know, people might be less likely to have psychosis with some of the substances if they have a safer supply to them. But even still, it's kind of probably about reducing the overall harms, because whether or not people have psychosis from substances, we know very well that they may or may not choose to continue using them. And I don't think that legal regulation would necessarily change that risk.
And I'll just add to that, like a prescriber-driven model is a form of legal regulation. That is, so we already do have legal regulation in Canada. It's just under a very narrow prescriber model. And what I think or hope to encourage is kind of an idea of legal regulation, not just outside of a prescriber-driven model in the case of some substances where that makes sense, but also a broadened prescriber model. You can still have a doctor's prescription or you know, under legal regulation, a nurse's prescription if we wanted to broaden the category of who can prescribe for certain substances. But like, we need to imagine something. We're very limited in how we think of a prescriber-driven model because we haven't experimented with much under the current prescriber model. So we can still have a prescription, but we can expand who can prescribe or where prescriptions can take place, or removing kind of the pharmacy element so that people can access the substances they need at, say, an overdose prevention site. These are all forms of legal regulation under a prescriber model. It's just a different way of conceiving of a prescriber model.
Great, thanks for that. Lots of interesting questions coming out of that as well too. Let's go to another one that's come in here. Who are the most important groups to engage in pushing forward with decrim?
I mean, I think probably the most important is people with lived experience and people who use drugs, like especially in Vancouver. And I think like the common phrase that they use in Crackdown in general, like that is heard, is nothing about us without us, which I really like. And I think like right now, the proposal from Vancouver, from my understanding, is that has not happened a lot. And really it's been looking to literature and policy. But I think that would be the biggest piece from my perspective.
Anyone else?
I mean, I think it's important that we also, like the public and other, like I think lots of different parties should be involved in reviewing that. And so I think it will be part of like, I don't know what the plans are for evaluation. Like they were pretty vague that they were going to like send it out for kind of public. So I'm not sure if it's gonna be like public opinion polls or different ways of doing that. But I think the public, and then I think certainly physicians and other healthcare providers, especially people who work with individuals who use substances, should be part of the conversation to talk about the impacts of different policies.
Great, thanks. So this question says, as we've seen with cannabis, legal regulation without decriminalization is problematic. How should these two relate? How do you ensure people are using the legal market? I guess what's intended is that legal regulation with still criminalization of other people selling in non-regulated environments is problematic, right? There's a thriving illegal market for cannabis, and now we're slowly putting in a legal market, and obviously the illegal market isn't disappearing, right? And so how are we going to balance, you know, opening things up with things being legal, but still wanting to have some public health restrictions, with obviously the illegal market not having any of those public health restrictions?
Yeah, I mean, I think it's a great question. I think that is like a very difficult balance to strike. And I think that it would probably take kind of like reviewing any policy that's put in place to really get it to a place of an appropriate balance. Because like you said, I think like with cannabis, for example, it might be that it like pricing and different things prevent people from accessing it that might drive them to kind of continuing in the non-regulated market. But I think in the future, it would be similarly just trying to strike a balance between kind of like cost and trying to minimize people entering the market, I guess you could say, while also balancing and making it accessible as compared to the criminal market. I don't know if you have further comments, Caitlin.
I would just say, I think we should have criminalization at all times for all substances, regardless of whether the substance is legally regulated, because there will always be an illicit market, because criminalization does harm to the most marginalized drug users. So I don't think anyone should ever be criminalized for possessing drugs for their own use, just given the abundant harms that flow from criminalization. But yeah, it is about striking a balance between ensuring that the legally regulated market is competitive with the illicit market, and that it actually is a viable source and supply for people that is as accessible, if not more accessible, than the illicit market, because people are in rough situations oftentimes and are going to be forced into making a decision that is the most accessible to them. And so if that legal market is not accessible, then the illicit market will prevail. So it's a tough balance, and I agree evaluation is going to be part of that.
Great. Well, I think we're out of time, but fantastic presentation, Megan. Thanks very much for your really important input, Caitlin. And unless either of you have any final words, I think we will sign off.
No, I think that was great. Thanks, Caitlin, for joining me.
Great. Thank you, everyone, for joining. Really appreciate all the people who joined, and stay tuned for the next What's New in Addiction Medicine.